This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, this is part 2 of pre-hospital burns with Krissie Stiles. So in the second part of this conversation, what we wanted to do is really break down some of the treatment modalities for pre-hospital burns with Krissie. We're also going to look at the considerations for transportation and some of the issues around longevity of transportation and pain management. We're also going to look at the management of burns in mass casualty incidents and some of the complications as well. And we're also going to talk about the importance of burn prevention and public education. We're going to look at some of the specialist treatment facilities and burn centres that these patients can go to. We're also going to dig into a challenging case that Krissie has faced in the past and really just examine a case that Krissie's really learned a lot from. We're also going to look at the psychological and emotional impacts of burn injuries, some of the rehabilitation for burn patients, some of the training and education requirements, and then finally the debriefing. So to this, I have Krissie Stiles with us. Krissie was on the last episode with us. She is a nurse with extensive burn and plastic surgery experience. She, of note, has set up a number of clinical practice guidelines, but fundamentally founded the British Burn Association Pre-Hospital Specialist Interest Group, which has been an absolute revelation and indeed moved a number of pieces of policy forward. Krissie, welcome to the podcast.
Thanks so much for having me back.
It's great to have you with us. Krissie, I just wonder if we could start and pick up where we left in part 1 and just approach some just the fundamental tenets of treatment, cooling and dressings in management of burns.
Yeah, absolutely. I mean, cooling is one of the basics of burn care. It's the first thing that we advise members of the public to do if somebody sustained a burn injury. And what we actually have realized is that most of us don't know what burns first aid is. So many patients still turn up through clinicians' doors having applied toothpaste, turmeric, butter, ice, milk, egg, all random things that actually could put the burn injury at detriment and is not exactly first aid. So this is quite a pertinent question for general members of the public as well as clinicians alike. So burns first aid is cool running water for 20 minutes, but this is only effective within 3 hours of burn injury. It's not effective after this time, and 20 minutes is what's required to promote wound healing, to reduce the size and depth of the burn injury, to reduce the likelihood of surgery, prolonged hospital stay, the likelihood of scarring. So cool running water for 20 minutes is actually quite life-changing as an immediate response to a burn injury. I've had some questions about whether, shorter periods of time is any more effective. Is it better to do some rather than none? And ultimately, yes, you do what you can as much as possible, but in the knowledge that, for example, 20 minutes will promote healing 4 times faster than 10 minutes of cooling. So there is a vast difference. So 20 minutes is what we advocate in full realization that it's a lifetime. If you're sat there, for example, with upset, screaming child or a person who's not compliant and you're trying to do the right thing. So all those barriers aside, ultimately, this can completely change the trajectory of that burn survivor. When you are delivering first aid pre-hospitally, there are a number of barriers, one of which is usually access to water. So paramedics on scene that arrive, you might have very limited supply of water or saline that you might carry. Certainly with saline, you might need to use it for intravenous fluid replacement rather than doing first aid. So access to water becomes a challenge, but we know that our data tells us majority of burn injuries happen at home. So actually you have very good access to a tap, shower, and you can utilize that at the time rather than rushing and transferring and going to hospital, which, as we previously discussed, quite often the hospitals also don't have easy access to showers or taps to deliver first aid. So if you can stay on the scene, deliver the running water for 20 minutes, and be very mindful of that ticking clock, that the 3 hours is ebbing away all the time when not doing first aid. The other question quite often with first aid application is the temperature of the water. So we always say cool running water, but it's often wrongly interpreted as very, very cold. And very, very cold water for 20 minutes is a very long time to sit in very cold substance. So you could cause hypothermia, and that independently can cause problems in not only locally in the burn wound, but systemically to the whole patient as well. So you don't want a hypothermic patient. So you cool the burn, but keep the rest of the person warm. And if it is an extensive big burn injury, you prioritize certain areas like faces, hands, genitals, feet, as a matter of priority for your cooling, and keep the rest of the person as warm as possible, or do segmental cooling, one arm, then the next arm, and hand over what you've done. We've cooled both upper limbs but haven't done the lower limbs. It becomes part of the handover and the ticking clock handover as well. You've got 1 hour left whilst the first aid is still effective. Clothing removal is important. You don't want to be cooling over the top of the clothes that have been in the fire or have been scalded, because ultimately they would adhere to the skin and you're not being effective in your first aid application. So remove clothing, remove jewelry. In babies and young children, we forget to remove nappies. So remove nappies, remove continence pads in older patients as well. So then you actually can cool the skin, the burn itself, and then you can put on the nappy or the continence pad back on, and you can wrap the patient in clothing or blankets, but cooling needs to be done directly onto the burn wound. And then for transfer, all that we advise is that you apply cling film. And that comes as a little bit of a shock. It doesn't need to be a sterile cling film surface. We know it's not sterile, but it is a very good wound cover for the purpose of ongoing observation of the wounds and for the purpose of transfer. It covers the wound. It is very pliable, so you can kind of wrap it around, the surfaces like axilla and elbows. It's non-adherent, so it's not going to cause any trauma for the patient. It's impermeable, so stuff can't leak through, but equally stuff can't get in. So it acts as a barrier. And it's very good for us to continue observing the wound as we transfer and as they get to emergency department, and then eventually when they get to the burn service. You've not wasted expensive dressings that then are cut off and put in the bin for wound observation. So the trick with cling film is, don't apply it to faces. We've had a few patients who turn up with cling film to face. It's not necessary. Leave the faces exposed, but everywhere else you use longitudinal layers, so loose longitudinal layers in strips. You just apply it literally to cover the wound. It is not a dressing. It is not a permanent wrap. So don't be tempted to wrap around the person's torso or wrap around their limbs, because it is actually not elastic. So if they try to breathe as you wrap them around the chest, they might not be able to breathe easily. And if you wrap around their limbs and they start to swell up, it acts as a constricting kind of belt, preventing blood supply. So very gently applying just to cover the nerve endings to reduce the pain stimulus of air on nerves. And that's very, very effective. It also acts as an additional adjunct to your prevention of heat loss in a major burn patient too. So cool for 20 minutes. It's only effective within 3 hours. And once you've done the cooling, you apply cling film gently in layers over the surface of the wound.
What's your thoughts on burns dressings, Krissie? So most ambulances do have these aloe vera dressings, which are impregnated with aloe vera to cool the burn. I think reading the instructions, they do say only leave on for I think 20 to 30 minutes because it can cause profound cooling of the body. But what's your thoughts on that?
So when British Burn Association were putting together our first aid guidelines, we looked into the evidence behind the hydrogel burn dressings, and there was insufficient evidence for us to recommend their use, especially in presence of a far superior method of cooling, which is water, something that has plenty of evidence for. So we say in presence of water, do water cooling, do not use gel dressings. So one of the other issues is that the hydrogel gel dressings often will market themselves as being a dressing as well as a first aid cooling adjunct and also as an analgesic. Three things that one product professes to do. And actually, we know it's not as effective at being a coolant, so water is way more effective. For analgesic purposes, if you've done the cooling and applied cling film, it does the same thing. It's covered the nerve endings, and that's where the analgesic effect is felt. You don't need a more expensive product to be applied in order for that to happen. And ultimately, if I'm the patient, I would want proper analgesia, please, rather than just an adjunct that supports that. And then as a dressing, it, like you said, if applied to a larger surface area and left on for a prolonged period of time, it could actually cool the body substantially enough for it to become hypothermia situation. It also will dry over a period of time. And the issue that we've seen in the burn services is that when the dressings have been applied, it takes away the responsibility for applying appropriate first aid because people see the gel on the dressing is on the patient, and I think, oh, well, they've had the gel applied, so we don't need to do first aid. The patient will arrive to emergency department who will also say, oh, the dressing's already on, we don't need to do anything about that. And then eventually the patient arrives to the burn service and it's too late to advocate. That 3 hour window is long gone. And nobody's done first aid because the gel has been on, and it's the least effective method of cooling the burn wound. So my thinking behind it is that we don't have sufficient evidence to advocate the use of gel dressings. For cooling purposes, I would always use and strive to use water or to make access to water available within the 3 hour window, and to hand over the responsibility for first aid to the next treating service if I'm unable to deliver it at the scene. With gels, I know that some air ambulances have kept it for the facial burn wounds, and I would say that unlike, well, I suppose like everywhere else, first aid is a priority because you're reducing the depth of size and all of the other consequences of the burn. Whilst the person is no longer on fire, or maybe they've scalded themselves, you've removed them from that injuring mechanism, but the injury is still ongoing. The heat is still in the tissues, and until we do the cooling, you're not actually reversing the damage. The damage is still being done, even though you think the patient is safe now. So if you're applying the gel, that cooling process potentially will be much, much slower than if you actually did the water cooling. And if it's my face that you're leaving the gel dressing for, I would much rather have the most effective treatment so that I don't end up with scarring and disfigurement on my face. So I would actually say that you can do the cooling for your 20 minutes, and then whatever dressing you apply, it really doesn't matter, because then you're applying something to make the patient comfortable rather than to actually deliver active treatment that, like first aid with water is. Does that make sense?
Yeah, it does actually. No, it does. Absolutely. Absolutely. And like you said, it's not only about the evidence base, but it's also about the handover of care and like you said, the efficacy of treatment actually. But you mentioned something really interesting there, which is around robust pain management, which would be not just the alleviation of sensation from maybe clean film or indeed from cooling, but it be it's more around the looking at opiates or indeed um, ketamine or otherwise, or indeed maybe more simple analgesics as well. We always used to advocate um, with Entonox, you can get people to sub-anesthetic doses if people take Entonox appropriately, and obviously you've got to mitigate some of the contraindications, but just looking at some effective simple and then maybe more advanced pain management. Could I get you to speak to that? Because just over the long, I'm mindful with critical care, even in the UK, you've got a real disparate variation in some patients take 5, 10 minutes to get to a specialist burn centre. Some patients it's 4 or 5 hours. In Scotland, it might be certainly 4 or 5 hours or more. Same in Wales. And so the critical care teams or indeed the ambulance teams are with these patients for a really long period of time or can be. When you approach pain management over the longevity of time, and just like you said, to make patients fundamentally comfortable, um, what's your approach?
So obviously there's the WHO analgesic ladder that we're all very aware of, and you incrementally increase the strength of the analgesics that you're able to offer to your patients based on the response and what's been effective, and you step it up, step it up. Um, with burns, usually, and especially with major burns, we flip that on its head and we start with really, really strong stuff because we know burns hurt. And if you're talking about major burns, you want to go in with really strong opiates and give incremental doses until it's had effect. But then you're also monitoring the patient. And we've previously mentioned that hypermetabolic response where the body actually chomps through your sedatives and your analgesics much, much quicker. So anticipate that it wears off quick and the patient needs it. So if they're telling you ultimately, the definition of pain is whatever the patient says it is. So, if they're telling you they're in pain, they're not making it up. Their whole body is injured. They've got skin loss. It's open to air. Everything is in that super hyper-inflammatory response. Is going to sting. It's going to be swelling. It's going to hurt like hell. So you want to make sure that you manage it. But it depends what's within your kit. So that's not to negate that actually even simple paracetamol administration is not going to be effective. That's fantastic. And especially in cases of pediatrics, if you start with, with what you have, the parent would be advised to give some paracetamol, give Calpol to your child whilst you're waiting for us to arrive on scene, because that's what you do. Your kid is in pain, that's what you would give them. And then when the more advanced skill set arrives, you can give them the step up and intranasal stuff, maybe IM, but ultimately you build up the analgesic support because they do need it. So I think ultimately I don't want to tell paramedic colleagues how to manage pain relief because you all know exactly what you're doing with that. The only surprise, I suppose, in major burn patient care is how quickly that pain relief wears off. And that's what might stump you a little bit. You feel like you've given a reasonably large dose, but the patient very quickly, wears it out and says, still in quite a lot of pain. Can you give me something else? So just be prepared that might be the situation. And if it's not within your scope or your practice set to be able to administer more, you need to summon another more advanced skill set that might be able to give that relief to the patient. Because we know that if they have a really bad experience with pain, it's not only linked to a poor wound healing and a more likelihood of infective complications with wound healing. So that's just patient being in pain. They won't heal and they're more likely to get infected. But on top of that, you're creating a situation of post-traumatic stress, a memory that they retain that's linked to that situation, to that injury. So any next intervention with regards to their wound care or anybody kind of even coming to assess their wounds, there will be responding with a lot of anxiety and potentially combativeness and aggression, just because you're freaking them out. You caused them pain, you didn't manage it at the time, and they're thinking it's going to happen again and again and again. So we want to make sure that your first interaction with the patient when you're managing their pain is as effective as you can possibly make it, to make sure that they're under control, and you build the trust of that patient. You build in their buy-in, you basically getting their buy-in into complying with you, into following your guidance and your support, because they now trust you, that they said they were in pain, you managed it really effectively, and now they go, well, what do you need me to do next? It's a fantastic therapeutic relationship, but it won't happen until we manage the pain effectively, and then you can ask them whatever you want. They will be very compliant and will go along with it. So pain management is a massive in burn injury care.
Yeah, no, indeed. And something you said in the last episode, Chrissy, which is of fundamental importance, is going through the parent, if it is a pediatric, if it's a child, and including the parent in all the treatment modalities, because that's almost the point of entry for that rapport building and the trust which is already there with the parent. So I think that is absolutely a fundamental point you mentioned in the last one. Chrissy, these are quite big questions. So and I'm mindful of that. There's a few big questions I'm just about to ask, which so I don't mind if the brevity of the answer, because some of these could be podcasts of their own accord. But one question would be, and it is really challenging. It's super challenging for all the pre-hospital clinicians worldwide, UK, Europe, US, and elsewhere. It is around the concept of, a house fire, which, or a block of flats fire. Let's take Grenfell as an example. It's a major incident. And you have this mixed modality, mixed pathology of burn injuries from smoke inhalation. Like we said, smoke burns at 120 degrees plus, lots of toxic elements to smoke. So just because you can't see the burns doesn't mean they don't have burns. But and multiple patients, just to add on to that. And quite frequently, these major incidents happen at night time, which adds another complexity to it. Visibility is poor. Patients come out at different times because they're extricated by the fire service at different times. So you might just get 3 or 4 critical patients at once. Lots of moving parts to this. Oh, and also bed availability, so availability of critical care services and burn services beyond that of hospital care can get soaked up super quickly. I guess my question is, from your perspective, can you speak to how just some of your reflections from previous incidents, or indeed learnings that you've just been privy to, just that some salient lessons that you've learned either from Grenfell or otherwise. I can speak to some of my experience being super challenging, and that's just even with just 4 patients that you've got to manage, because you've got the walking well, who are coughing, understandably upset, but then 3 to 4 critical care patients, mixed modality, pediatric, adult, and can absolutely max your, because 1 patient can max your services out. So having 4, you really have to flick it back into this triage mode and just cover the bases, do the basics well. Could I get you to speak to just your reflections on any major incidents?
First and foremost, NHS actually has issued a really good guidance in 2020 on guidance for major incidents and mass casualty events, that has a fantastic section on managing casualties with burn injuries. So I would say anybody who wants to look this up, to reference that, look it up. It's got very clear guidance. Ultimately, ATLS approach remains. You still need to do your primary, secondary surveys, and you need to try and estimate kind of the impact of injuries, the severity of injuries, and try to prioritize where you should be delivering your care. So even if you're looking at a tool like the 10-second triage tool, by the time you're actually assessing your patient, walking, bleeding, talking, quite often most of these are your burn patients. They will be awake, they quite often will be talking, they're less likely to be hemorrhaging catastrophically or have any penetrating injuries. Usually it is a burn injury only trauma. So then you're back into your kind of ATLS approach. airway, breathing, all the usual steps that you would take. So in that sense, it's not any different, apart from you have many of them at the same time, and potential for deterioration due to that edema and airway compromise is massive. So some of the key points, I suppose, would be to still be very wary of airway edema, and if in doubt, you need to find somebody who can intubate that patient. We never cut endotracheal tubes, so if you have intubated, leave it long, because we know they're going to swell up over the next few hours. Obviously, don't forget C-spine. We do, whatever the circumstance of injury, if they were thrown or jumped, or ultimately it's trauma as well as burns. So don't forget C-spine as well. If you're doing your very quick guesstimate of burn wound size, don't forget that you don't include erythema. So anything that looks red like sunburn, and there's not skin loss, you don't count it in the size of your burn injury estimation. And one of the key points I think we made last time is about hypothermia being the biggest killer as well. So if they're getting cold, you need to manage that. So these are kind of very, very simple things that you rightly said, a handful of patients would overwhelm a local burns unit, and would start to request maybe mutual aid from other units outside of the network. But actually, in any kind of major incident, normal care pathways would not be in force. They would be stopped and the burn services close up. Burn injured patients will be triaged on scene and then transferred to the nearest hospitals that are receiving these casualties. And actually, we would then issue the burns incident response teams, who are mobilized to go to those hospitals that are managing the casualties, to help with the triage and allocation of patients across the nearest burn services. Quite often we would triage them outside of the network as well, because obviously local burn services need to manage the patients they already have. So it is a very stressful situation to find yourself in, but going back to the basics, to the skills that what's going to kill my casualty first, who takes priority, and you just act accordingly, and check up the guidelines, because it's all in there. Just refresh it in your head what you would do.
Yeah, that's fantastic. And I think we'll put the guidelines in the show notes actually so people can refer to them. Krissie, just looking at the long-term implications and ramifications of burns, one of the things that we don't necessarily get archetypally as paramedics, or indeed EMS staff, or pre-hospital emergency medicine colleagues, is either follow-up or the longevity of care, and the long-lasting effects of these injuries to patients. And it might be something that you maybe have a bit more of a unique perspective on, around the long-term complications and sequelae of severe burn injury. Could I get you to speak to some potential long-term complications and some salient points?
So we talked about the kind of that systemic response that the burn injury kicks off, especially major burns we're talking about. And the consequences of that significant systemic edema could be multi-organ dysfunction in the initial stages. And that's hard enough to manage. On top of that, they now have lost their biggest barrier, which is their skin. So they suffer quite frequently from recurrent septic episodes, and every time you do a dressing change, you instigate a septic shower where they become really hypothermic and really unwell, very tachycardic, unstable. So all of this in that kind of initial acute stage, prolonged periods of immobilization or sedation, multiple returns for repeated surgery, so going back and forth from operating theatre. On top of that, they're your typical immunosuppressed patient as well. So you're trying to manage the infective complications, lots of antibiotics, lots of multi-resistant bugs that we're trying to deal with as well. So if somebody survives this, you have to appreciate that they've come from, that they've healed their wounds, their body has been shaken to its core, every organ would have been affected by this massive burn injury. So not just the skin, everything else internally too. They come out having lost masses of muscle mass. They have muscle weakness as a result of that wasting, and obviously they'll then have loss of strength and loss of function, whilst it also poses massive challenges to us in the unit as we're trying to rehabilitate the patient from day one. As soon as they arrive, their therapy starts. We start to passively exercise, then splinting into certain functional positions, and then actively rehabilitating and moving them, building their strength as much as possible. But you're working against a body that's become quite catabolic. So the body in a major burn patient uses muscle mass as energy source. So it doesn't attack the fat stores, it goes for the muscle because it's the greater producer of energy. So sadly, you lose muscle mass, then it's much harder for you to build strength. It's much harder for you to get out of bed, start walking, even feed yourself. You become really, really weak. So lots of patients then complain, and not complain, but suffer with massive fatigue and just lack of strength. On top of that, their wounds have healed, but the scar itself has a life of its own. It continues to mature and harden and thicken and contract over a period of time. And if left unmanaged, it becomes something that really will affect your ability to stretch and your ability to move your joints. And obviously, the scar itself looks unsightly, can be incredibly disfiguring, and causes lots of psychosocial issues for burn survivors. So you've got muscle weakness, you've got your contractures and scarring that is dry, splitting, contracted. It affects your movement and your strength. And then on top of that, you have ongoing pain issues. You might have neuropathic pain where the scars have actually trapped your nerves, and then you have the sensation of pins and needles or sensation of electrical shocks running through your scars. You could have pruritus, significant itch that doesn't allow you to sleep. So you have pain, neuropathic pain, you have sleep loss. You can't sleep because you're itchy or you're too hot or you're in pain. And then the stress of living with consequences of burn injury, the stress that your body has experienced and continuously is experiencing, and then the psychosocial stress of surviving a burn injury and going back to what used to be your life, but it's not the same anymore. So there are major rehabilitation issues, and we continue supporting burn survivors, not just with the kind of acute and wound care. We've healed your wound, and after that, we realize that there is a massive support need that continues, and that's through therapy, psychotherapy, physiotherapy, occupational therapy. All of this is very, very needed. One of the key issues in children is the growth inhibition. So if a child has a major burn injury, that could actually stump their growth for about 3 to 5 years after their wounds have healed. And that's a massive implication on that person. So burns are not just skin. Burns are literally every organ in your body, and it will affect them as such. So we need to be very aware of the importance of getting their strength back, getting their function back so they can live their life, getting the nutrition supplementation, because that catabolic state continues for up to a number of years after the wounds have healed as well. So you're healed and you're out of the burns unit, but you still look emaciated because your muscle mass is still being targeted for energy source. So you need to build muscle, you need to eat well to build muscle, and you need to continue trying to reintegrate yourself into some semblance of a life. And for that, we have many charities and peer support networks also provided by the burn services that, in recognition of that fact, continue holding the burn survivor's hand for as long as they need it. In a snapshot.
Yeah, indeed. I mean, it's yeah, you're right. It's multifactorial, and the rehabilitation is multifactorial in lots of ways. There is a really interesting. I'll put some in the show notes exactly some of these referral services and rehabilitation services that you notion towards. Krissie, could we just pivot and look at the public health and education to the community that's put out there? I think since I was a paramedic and then into critical care, I'm absolutely paranoid about hot drinks on the edge of surfaces, especially with kids with pediatrics. And soup or indeed anything on edges of surfaces that can be pulled over kids, I'm just paranoid
Yeah.
about. But could you speak to the efforts to, and you mentioned earlier about the adage of good first aid, good burn first aid can be initiated by the family, by anyone. Most people got clean film in their cupboards. Most people have got access to cool running water. Could you speak to whether you see these messages effectively being sort of transmitted or conveyed to the community?
So every year we run a National Burn Awareness Day. It is on 16th of October this year, and that's the whole of the burn specialist community. And we invite our emergency service colleagues, we invite our healthcare partners, and in fact, anybody who deals with caring for patients with burns. We ask you all to join us in promoting burn prevention in the home, as well as the knowledge of appropriate first aid, because we know that most of the burn injuries happen in our safest places in our homes. The most dangerous places in the home are kitchens and bathrooms. That's where majority of the burn injuries happen, and a lot of these, like you alluded to, happen in young kids, and most of them are under 5 years old, and in fact even larger proportion of that demographic is under 2. So these are literally babies and newly mobile toddlers who are getting burnt, usually with hot liquids that they don't themselves drink. It is purely adults cooking, adults drinking hot drinks, and that's what they get access to, and that's how they get scalded. So our efforts are to try and avoid this absolutely life-changing complication that can affect a family in an instant, and then your life's changed forever, because of not just the frequent hospital trips or potential need for surgery and disfigurement and scarring, and the fact that scars in children don't grow with them, so they might require surgical reconstruction every few years. So it's a massive impact that it's really difficult to get across through the public health messaging, because if it's never happened to you, you have no concept of, oh, I have so many messages that tell me, don't do this, don't do that, don't do that. We're flooded with safety messages and health messages, and somehow it doesn't sink. And it only sinks, sadly, when somebody or somebody in your family or yourself have been affected by a burn. And all of a sudden, then you understand the significance of these messages. And, we would welcome anybody's help, in public health and emergency services and in education. The more of us try and troubleshoot how we can get this across, that it is kitchens, it is bathrooms, it is boiling water mainly, hot drinks that are causing injuries to very, very young babies and children. Yes, most of the families that are affected are from low socioeconomic backgrounds, but equally, a big bunch of that population also don't know first aid. So if we can work on prevention, we can equally work on educating children and their parents as to how to do first aid, what burns first aid is, because so far we are telling people, but we're certainly not seeing an equal and measurable response in reduction of those injuries. They still keep coming, and they're reasonably consistent year in, year out, with the latest most injuring factor across the young children demographic being hot water bottle scalds. It's the second year running that we've noticed that children are getting burnt and scalded by hot water bottles. So it's something that we're really keen to try and prevent and educate parents on the risks related to that.
So just pivoting slightly and looking at a slightly different topic around um, the latest advancements and research. I remember on the last episode, you said there's real dearth or lack of research within burn care, and it really is an evolving topic, an evolving domain, really, and lots to do, lots to be done around research. I think one of the, and I'd just like you to speak to this if that's okay, Krissie, is just one of the main innovations in my mind was the adage of a major trauma network, whereby we could start to put specialisms all into one place, such as burn care, trauma care, stroke care, heart attack care. And could I get you to speak to the adage of major trauma centers for burn and indeed burn specialist centers, just being, I guess, in a way, a facility which really kind of coordinates and communicates and brings short-term, mid-term, and long-term specialists together to improve morbidity and fundamentally mortality, but also morbidity. Could I get you to speak to your perspective on burn specialist centres, what they're looking for, what they're after? I think now, if I'm not mistaken, the certainly the protocol in certain areas is just to go to the nearest, and then there's a referral through so that they can do the initial phase of care in the ED. Could I get you to speak to specialist burn centres?
Yeah, so there are four burns now. Like basically, our geographical areas are split into burn care networks. So we have one in Southeast, we have Southwest, we have Midlands, and we have the Northern burn care networks. Scotland have their own, so it's part of the trauma network, as you said. Ireland also separate a trauma network there too. Within each network, there will be a cluster of specialist burn services. Unfortunately, unlike the best guidance for us and as part of our burn care standards, we are sadly not seeing many burn services that are co-located within the major trauma centres, which would be the ideal outcome for our patients. So at the moment, the way that the patient care pathway works is that when the person is injured on scene, they are attended to by the emergency services. The ambulance service will then transfer that patient to the nearest trauma unit or trauma centre, depending on the severity of the patient's injuries, but it tends to be the nearest DGH. And then they're stabilized within that hospital that does not have a burn service. And then that ED will refer the patient to the specialist unit, and the patient needs a secondary transfer with another ambulance service to try and take them to the specialist burn service. So that's why there's quite often this big lag, this big delay of us seeing our patients and us being able to influence the care that patient receives. So that's why podcasts like this, educational sessions, our presentations at conferences to people who treat our patients first are really important. On top of that, we also offer the referral criteria, and there is a national referral guidance from the NHS, which is generic to kind of UK wide. There's a minimum threshold for referral into specialist services. So it sets out quite clearly, these are the injuries that we know are going to be severe, we know they're going to need the support of the specialist burn services. So if you've not seen those, check out the National Referral Guide, Burn Care Referral Guidance, because that will tell you that all big, deep burns, that are require surgery, burns that are complicated and won't heal, certain age groups, all of this is included in there so that you know, will this patient need to go to the specialist service or not? That's all part of that triage and that's part of that threshold for referral. So it's always really helpful information. And ultimately, burn services are hubs that are acutely specialist. We see these patients day in, day out. The whole team is centered around the acute care and the rehabilitation of that burn survivor. We also have good links with the charities that support children with burns, families that are affected by burns, as well as adults with burns. And they provide a lot of peer support as well, and additional either financial support or rehabilitation support on top of what the NHS is able to provide too. So we have a fantastic network that the patient and their family can benefit from if only they get as far as our doors. But they will only get as far as our doors if the clinicians choose to refer them to us. Otherwise, we don't know that the burn injury has happened. So you talked about the latest advancements, and the latest advancements is that most of the burn care networks are now using a telemedicine system, because nothing speaks as loudly as a picture. So we really love to see an image of burn wounds before the patient is referred, so that we can A, guide the treatment locally. So we do the remote assistance almost to that treating emergency department. But equally, we then know what to anticipate. If that person needs to go to operating theatre straight away, we can start mobilizing the theatre team so that the patient comes. So it's almost like that advanced alert system for us. Patient needs your help. These clinicians need your support. We advise what to do, how to stabilize them, what not to do. And then we know to anticipate that patient's coming through our doors in the next hour or so. So that's brilliant. So I think overall, ideally, would be based within the major trauma centres, and some burn services are, and that model works really, really well. But across most of the country, that's not the case. So there is a massive delay, massive lag before patients get as far as us, and they are in the hands of non-specialist care providers. And access to burn services should be possible. So if you wanted to pick up the phone and say, actually, I'm treating this person, this is where we've got to, this has been our assessment so far, any further guidance on this, we would be able to advise as to, anything else that you might need. So it's brilliant to pick up the phone and just ask for help, ask for support too.
To your point, actually, Chrissy, around affecting the trajectory of care earlier on through that engagement, telemedicine engagement. So, like you said, a picture speaks 1,000 words. So people can actually see specialists can see the severity, and like you say, start to steer treatment an hour or 2 hours or even more before they receive the patient, which is fantastic. Chrissy, could I get you to speak to a challenging case that you've attended, that you've learned a lot from, and or you've reflected on, and kind of, yeah, just taken sort of lessons away?
I think it's really tricky to speak to any specific ones, because I think that most of us will have a patient in mind, especially with burns. These patients tend to stick in your memory like glue, and they don't leave you very easily. And ultimately, I worked in an intensive care unit of the burns unit, so there's been multiple throughput of many patients that I've looked after. Each one of them was special in their own way. They are some of our toughest admissions, but also that makes for the best shifts. They're often night shifts, like you say. These admissions to these situations tend to happen at night. And I absolutely love the part where the whole team comes together. You mobilize your whole team, and within minutes, many people are around you to support you in admission of that one person. And obviously, I'm very aware that in the pre-hospital environment, you don't have that luxury always. And certainly in the emergency department, they're just kind of traveling through your service until they get to the burn service. So again, you might not be privy to that, but certainly in the burn services, I loved taking on the referral, then orchestrating the admission of the person, and mobilizing the team around me and around that patient. It's like the best feeling. I think the patients that triggered me the most were patients that were very relatable to me, were my age and my circumstance, and I could almost project that this could have been me. And they were the trickiest ones for me to look after personally. But it's not necessarily the patient that I've been involved in, but she's publicly spoken about her injury, so I feel happy that I can share. Danielle was a survivor of 85% surface area burns. She worked with me alongside of me when I worked at the Katie Piper Foundation, which is a charity supporting burn survivors. And Danielle was a peer support worker, so she supported other burn survivors who were coming in for rehabilitation with us. Her injury happened now about 7-8 years ago. She went away with her parents for a holiday in a motorhome. They stayed at a caravan park, and it was 31st of December, and they went to bed 31st of December, and she woke up to the motorhome on fire. She and both of her parents, her dad managed to get out, and she was in the motorhome with her mum. Mum would have had to, mum was sat was safe, not in the fire, but mum was reluctant to walk through fire to get out of the motorhome, and Danielle actually had to shout her out of the motorhome to get out. Danielle's own account is that she wasn't aware that she was injured or that she was on fire, but her feet really hurt. And she said when she was walking out of the motorhome, she felt like her feet were like flip-flops, and then eventually realized that actually the skin of the soles of her feet had come away. And as she was walking, they were flip-flapping as she walked. She took herself to the side on the grass, and bear in mind this is December, this is kind of 31st of December on 1st of January period. She said her clothes were molten onto her body, so she pretty much was naked in December, sitting down on the cold ground, severely burnt, 85% surface area burnt. Fire service arrived on the scene, and nobody came to her. She felt that maybe they didn't, maybe it's not their remit to do first aid, maybe it's, that they don't know what to do, but they were busy putting out the fire of the motorhome, and nobody actually attended her. Eventually, about 15-20 minutes later, when the paramedics arrived, then people put a blanket around her and then took her away. But later on, she was told that she only had 1% chance of survival, and she survived. She had over 200 hours of surgery. She was very, very sick in induced coma for many months. She's had multiple skin grafts. She has significant scarring all over her body. But many, many years on now, she's supporting other burn survivors. And she's now a mum. She's adopted children, and she's very, very happy. But at the time, I think her experience on scene was that nobody came, nobody recognized that she was badly injured or that she was in need of somebody to keep her warm or somebody to just put an arm around her and say, I've got you, we'll just wait for paramedics together. And that came as a bit of a shock that's what happens to burn survivors on scene, or certainly that was her experience. And she describes this massive emotional journey where almost it's not, she didn't feel like her life was worth living. Like, that's it. She in her own words, that her life died in a fire. What's the point? And it wasn't until she went to a burn survivor weekend through one of the charities that she met others who've been affected by burn injury, and she recognized, oh my God, there's many of us. And they know exactly how I feel. They know exactly what I'm going through. And it wasn't until that point, despite all the clinicians who've been supporting this massive burn care team, and it just speaks to the fact that we as clinicians can only go so far with burn survivors. We can only explain to them so much, but we don't actually know what it's like to live with a burn injury. But the other survivor, what the other burn survivor can give that person is invaluable. And that's where charities like Dan's Fund for Burns, Children's Burns Trust, and the Katie Piper Foundation are absolutely instrumental in bringing that social support network of peers who know exactly what you're going through. So if any of you have ever been affected by a burn injury, if you know somebody and they haven't reached out to these burns charities, I would say it is invaluable. It is absolutely incredible what they do, and the support they offer is something that we clinicians cannot reach and we cannot achieve. So just to be aware of that. So that's Danielle, and she is absolutely amazing. And there are many, many like her who have done so many amazing things after this horrendous life-changing injury that actually did not define them and did not end up being life-ending.
Krissie, as we're just coming to land on the conversation, could you just speak to the training and education requirements for pre-hospital providers? I'm mindful you sit on a number of national boards and indeed teach at universities. Could I get you to speak to maybe some of the priorities going forward that you see for pre-hospital providers?
I think generally more education on burn care would be fantastic. I mean, sadly, the pre-registration curriculum doesn't always fully address the assessment and management of burn injuries. I've experienced it as a pre-registration nurse, and I know certainly for universities that maybe are not affiliated with burn services, there isn't that mutual exchange program where clinicians or trainees they're not getting the burns content, and yet once qualified, we're expected to know what to do in these really tricky, stressful situations. So I would say that there are national and regional courses that are run by burn specialists, and we welcome all healthcare professionals who care for patients with burns as part of your clinical practice. We offer it to all emergency services as well, so you don't necessarily need to be a clinician, could be firefighter. If you're interested, you're in. There is a nationally recognized, and actually it's an international course called the Emergency Management of Severe Burns course, known as EMSB. It's a standalone one-day course, and it's provided by the British Burn Association regionally all across the country. Covers all principles of emergency management of severe burns, and there's lots of practical exercises, moulage scenarios. It covers everything you need to know. So if you haven't done much in way of burns training, that is a fantastic course to try and get enrolled on, and that will be available on the British Burn Association website. There are also local universities that offer courses. So University of East Anglia, UE Bristol and Swansea University all offer courses in burn care, and you can reach out to those and check them out. And some regional burn services actually invite they're referring clinicians and professionals who treat burn services outside of the specialist service. Actually, we invite them in for study days. So one-off days, they're often free of charge, and you come in and learn about burns from people who look after these patients. I wouldn't say there's anything specific. I would say look up the guidance. If you're not sure what to do, look up the referral criteria, look up the mass casualty guidance. But equally, just know that the basics work incredibly well. In big burns, airways, massive concern, smoke inhalation, big concern. They get cold very quick, so keep them warm. First aid for the areas that you know are going to matter to people in the long run. All of these things are just very simple interventions, something to notice, something to do about it. If you noticed it, what you're going to do about it. So courses give you structure. ATLS approach gives you structure. Your training gives you structure. And in situations of stress, we fall back to the level of our training. So it's really important to make sure that if you're interested in it, look it up, read it up, because next time you come across a casualty with burns, you will actually know, oh, okay, I know what to do now. Like, these are the basics, I'll follow that. So there's plenty out there to support. Just do your research, check out the courses available. And if you don't know where the courses are, reach out to your regional burn service and say, I'm really interested, where can I go?
Listen, Krissie, that's a fantastic place to finish. And I just want to thank you for the past hour. Actually, it's been fantastic just to get your thoughts and reflections over the past two episodes, actually. This is such a huge topic. And, you know, I could probably we could probably go for a third part three, but I will leave it for now. But yeah, just thank you, because it's really, there's so many nuances and so many salient learning points just from your answers, which are so pertinent to pre-hospital care and, you know, providers up and down the country, but globally as well. So thank you for your time.
That's all right. Thank you so much for having me. It's been a joy.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.